which went through Parliament, was never signed into law by President Kibaki because of pressure from the private sector. We thought that universal health care, the way it was put in the bill, would rob them of patients, which they were dominating. But fortunately, with the new constitution, Article 43, which says that every Kenyan has a right to quality, affordable, and accessible health care, the government is compelled to provide universal health care. And one of the 4 pillars of the Jubilee government policy now is universal health care. And as I speak now, 5 counties in fact, have been chosen to pilot universal health care in Kenya. The county of Nyeri, the county of Machakos, the county of Isiolo, and the county of Kisumu. And I speak now in my own county, Kisumu. I'm being briefed on a daily basis of extremely intensive activities to enroll people in National Health Insurance Fund. If you remember, well, Kenya was the first country really in independent Africa to establish a national hospital insurance scheme in 1966. At that point in time, it was established specifically for public servants because public health facilities were very good then, but the government felt that the civil servants needed a health care insurance to make it possible for them to be admitted to private hospitals. At that point in time, Kenyatta National Hospital was a hospital of choice. In fact, patients should be referred from Nairobi Hospital to Kenyatta National Hospital, or the then Princess Elizabeth Hospital to King George Hospital. When the first head of public service died, Mr. Garmira, he died at Kenyatta National Hospital. But over the years, the public sector has deteriorated in healthcare delivery. It doesn't mean that the public health in Africa, sector in Africa cannot deliver good healthcare. It has done before and it can do it again. And that's one of the reasons why there's now universal healthcare initiative in Kenya to recapture this lost glory. Let me just tell you briefly about the 5 counties piloting UHC. One of the reasons why the president decided that we have this pilot was to ask one question. What do we need in Kenya to ensure that universal health care succeeds? So he said, let's take 5 counties and ask, why can't you deliver universal health care? What do you lack? Is it equipment? Is it personnel? It is pharmaceuticals, non-farms? So the 5 counties were asked to do a baseline survey to find out where the gaps were. Because universal health care must begin from family health, community health, the national referral facilities. So we are supposed to analyze the whole system and find out where the gaps are and fill these gaps within 1 year and see how far we go with universal health care. One of the things we did in Kisumu was first to find out how many people could enroll in NHIF. And we found that out of a population of 1.2 million, and if you take about 300,000 as kids who are dependents, we found that there's another 300,000 people who are indigents, who cannot afford. So the county government must pay for them. And that's what we're prepared to do now, to pay for the indigent to enroll in NHIF. Now you remember some time ago when I was Minister for Medical Services, contribution to NHIF was very limited. It could not cover much because it was based in 1986 figures. When I tried as minister to increase this contribution so that NHIF could cover both inpatient and outpatient care and enlarge the area of coverage, there was a lot of resistance. But we succeeded in the end. An NHIF, which was originally only covering inpatient care, was then enhanced to cover both inpatient and outpatient, and to cover many more ailments than just what it was doing, and also go beyond just covering bed costs in the inpatient to cover other services. We have gone a long way in terms of having a comprehensive healthcare system. Now, however, we want to go the whole hog and make sure that when you are sick, you get full coverage as outpatient and inpatient, but a contributory system. Not like the British one, National Health Services, which is a little bit different. I think this experiment, not this experiment, this initiative is going to succeed because Kenyans are very determined. Where you as diaspora come in is in terms of technology, knowledge, and collaboration. Because we are not going to be able to build the public sector hospitals to optimum level in a very short time. We need a lot of investment from private sector and from individuals. In Kisumu, there are certain areas where we realize that we are really backward. For example, in specialized services like oncology, renal services, cardiology, sickle cell, and wound treatment. Now, 75% of kids born at Jaramogi Oginga Odinga Teaching Arifo Hospital are sicklers. That's a very high percentage. And you know, sicklers very soon have problems with wounds. So if you're going to deal with sickle cell, you might deal with wounds as well. So we are collaborating with some Kenyan doctors and Americans from UCLA to set up a sickle cell and wound institute at Jaramogi Oginga Odinga Hospital. We are also collaborating with a lot of your types here in the US to put up West Kenya Comprehensive Cancer Care Center, again at Jaramogi. So we encourage you in this regard to join your colleagues who are already working with us. And Governor Chepkwony is here. Governor Chepkwony is also putting up a cancer care center in Kericho. Again, collaboration with people in diaspora. And we are also collaborating with Kenyans, both in diaspora at home, lawyers, doctors, businessmen, to put up a special hospital dealing with cardiology and renal cases called Victoria Development Corporation. This is a business. It's not being put for missionary purposes. It's being put so that they can make money, but they provide a good service. But since we are going to have universal health care, people will be able to afford being treated in this hospital. So this collaboration between the public sector and the private sector, especially where you come in, because sometimes, that's what I was saying, where's Maggie? When I was asking Maggie about the idea of, where's Maggie now, it's gone, the idea of entrepreneurship. I do believe that if you're going to have universal health care, it is not just a question of making the public sector work, but also making a private sector work where people can have access because you have universal health insurance. So don't be afraid to come and venture in putting up a facility on a private sector basis. An entrepreneur is not a missionary. An entrepreneur is a money maker. You come with a hard nose and a tough heart. That's why I was using the example of Dalamea, not because NLS is still, but when Dalamea came to Kenya, he came with a hard nose and a tough heart. When he found that the cows that he had in his farm in Roysambu could not withstand the weather or could not produce as much milk as he could, as wanted, he went and imported a bull from New Zealand to crossbreed with the Zebu cows. When the bull came, you know, it was time to mate, and the bull was just standing there. Could not run because Zebu cows from Masai land, if you wanted to mate, you have to chase them. So then Dalamea said, now what is this? Dalamea was tough. He then invented artificial insemination. The fellow who brought artificial insemination in Kenya was Dalamea. Through her being a hard-nosed person, finding out what the problems are and solving them on the ground. So for me, I believe that an entrepreneur is somebody who wants to make money, wants to invest for philanthropic purposes, but is determined to face the problems. I'll give you an example. Last year after the elections, I had been elected a governor, and people were demonstrating in town. I couldn't just tell them to stop. I had to demonstrate with them, but control them. But because I was demonstrating with them, in the end I had the authority to tell them, stop demonstration, let's all go home. And they did, because I found a method of dealing with them. Since then, they have not demonstrated up to now. Because I told them, next time you're demonstrating, you must get permission from me. I'm the chief demonstrator. So these things are really, I'm challenging you. The field is virgin, the field is there. Come with your knowledge, needs come, let's work together. You can do much more than you are doing in Rongo. The other one thing I wanted to say is that if we engage, like Janet was saying, we must connect, collaborate, and catalyze each other. And you can come with your feet in both places. You're working in Kisumu, but you're also here. That's allowed, because the world is now global. Don't think that you have to close up business apartments and come lock, stock, and barrel. No. We can make an arrangement where you are spending 3 months in Kenya, 6 months here, and so on. Like the guys we are doing sickle cell center with, they just in Kisumu the other day, they're back in USLA. They will come again in September, and so on. These things are possible, and I think let's work together in that. But there are certain areas, just to say this before I sit down, there are certain areas where we really need you specialists from the West, especially Kenyans. We need hospital administrators. I don't believe myself that because somebody's a doctor or a nurse or a clinical officer, they are qualified to manage a health center or a hospital. Doctors are the worst administrators. Yeah, but unless you're trained in hospital administration, you become a really bad administrator. When I was Minister for Medical Services, I advertised that we needed the manager of Kenyatta National Hospital, a non-doctor, and the doctors almost rebelled against me. But we recruited Richard Esiante, who had been Deputy Director of Kenya Wildlife Service. And when Richard stayed there for about 6 months, doctors appreciated the changes he made in 6 months and said, this is the kind of thing we need. Since then, Kenyatta National Hospital has not had a doctor as the administrator. But in Kisumu, we have these doctors managed Jaramogi Oginga Odinga. It's a disaster. One, because really their mission is not to administer, it's to treat people, do research, and then go home when the dog tired, have a drink or two, wake up the next morning. Those we need. The other thing, the people we need in these areas, let me tell you, we need medical physicists. Especially because cancer is such a big thing now. But in a bad way, not in a good way. And we are putting up cancers. We are not going to have a successful cancer diagnosis, treatment, and care without having oncologists. Oncologists are useless without having medical physicists. So we need both oncologists and medical physicists. Along with that, we need cancer nurses or oncology nurses. And there are plenty in the West. We don't have a single oncology nurse, maybe recently, but not when I was Minister of Medical Services. We need them, those specialists, in as much as we also need people to read the pediatric sciences. You're right, there's no pediatric hospital in the whole of Nyanza, though we have a big pediatric department in Jaramogi Oginga Odinga Hospital, but it is completely oversubscribed. A pediatric hospital will not only treat, but will train as well. So when we go to Parklands tomorrow, let's have that discussion. Now, lastly, you touched on ECDs. We governors here are charged with the responsibility of early childhood education or early childhood development. I will tell you, in almost every county, without fail, a lot of initiatives have been taken in early childhood education. But because we were starting from so far, because early childhood education are not being paid attention to, the goal of having optimum ECD education is still far. I think in almost every county, Governor Lelek will tell you, Babaya will tell you, in almost every country we still feel very far from giving full ECD establishment, teachers, and so on. In the whole of Kisumu County, I cannot believe it. We have very many primary schools. Each you have an ECD. And that is not enough because a primary school, for example, or at a primary school in my village, with 600 primary school kids, and you only have one ECD center. Cannot be, because that ECD center has only about 70 kids. But those who will be admitted into standard 1 are very many. So we need to invest a lot of ECD teachers, ECD equipment, and so on. And we need to also begin teaching our kids from ECD modern ways of learning. Not the one I used to do when I was a kid. E. That is good. But now there are other things like social media that a kid needs to get known from. So will you help us in that? Finally, when we come to resources, counties have been urged, and Madam to put more and more money into health. But there's only so far that you can go. For example, this year, out of a budget of 3 billion Kenyan shillings, we in Kisumu have allocated, 9 billion Kenyan shillings. We in Kisumu have allocated 3 billion Kenyan shillings to health. But even that is not enough. But the only way we can expand allocation to healthcare is to increase domestic revenue allocation, which has its challenges, as Babaya will tell you. Kiambu is one of the best examples of a very well-improved revenue collection system. But even then, he will tell you there's still some problems to collect enough. For example, you can't collect enough in land because valuation roll is not complete, or where it is complete, people are still paying the same rent per unit value of land, which is now being used much more productively. You have to revise that. So all these things are coming on at the same time. Now, the only thing we can do is welcome you to come and solve the problems. The doors are open. Don't be afraid. Msiogope, sisi tuko tayari kufanya kazi na nyinyi huko Kenya. Basi kesho, basi tutaonana huko hospitali, lakini I assure you, all of us here are ready to work with you. Thank you.
Thank you very much. A coffee called Kenneth, Professor. We will not take any questions at this time. We're running very short of time. We have a 30, is it 1 minute or 30 seconds, Mr. Ndogo? How long is your presentation? He's doing a book launch. How long is it? Because if more than a minute, we won't have it.
20 seconds.
20 seconds. I'm going to hold the mic for 20 seconds, so come on. No, we can't because we don't have time. We exhausted all the time. We will meet again during lunch and during dinner. We interact with people, we ask questions directly because we don't have, we are almost an hour into second session, which is very, very important to the diasporans, and they are really here for that session. Come on.
Good afternoon. Thank you very much, the governors, for coming up here. What is interesting is when you read the stories about the governors, and when you meet them, it's totally different. That is so wonderful. So it is good to see you, because when we see you on face to face, you are just normal human beings. Yes. But when we read on the media, we are like, who are these human beings? So continue coming, continue showing up. I need somebody to turn on that computer, because it's dead, it's dying. Just somebody click on it. Just make it alive. Now, the chairman of the governors talked about a very important topic that I want to talk about. I deal with conflict resolution. And when you talk about conflict resolution, can somebody help him turn on the computer? It needs to be turned on.
Where's the power?
The keyboard. Yeah. So the question is, what is mediation? When we talk about mediation is like counseling. Because when we don't understand what people are suffering from, we cannot resolve that issue. The computer is there. All you need to do is to turn it on. Mediation is the biggest investment we can make as a country, as a government, because what we are seeing now, there is a lot of conflict, but people don't understand how to deal with conflict. If you don't understand how to deal with conflict, excuse me. I think the computer is not on. Oh. Anyway, I'll improvise. So, I used to be a teacher, and being a teacher, we were taught to improvise. So let's talk about mediation. What is mediation? What is the difference between mediation and going to court? Mediation is a system where you help people solve their dispute without really going to court. Mediation is where you, as a mediator, my job as a mediator is to bring the two people who are in dispute and help them resolve their dispute. Now, once they resolve their dispute, they can sign an agreement. That agreement will be honored by the court. Beginning 2016 in Kenya, the courts in Kenya have allowed now people in Kenya to be certified as mediators, so that all these disputes, what is happening in Kenya and here in America, there are so many. I think one of the governors was saying, America has become a country where everybody is suing everybody else. Interestingly enough, in Kenya, we are doing the same. We are suing everybody else. What is happening in the court system? They are becoming overcrowded. Here in America, this is what they do. When you go to court, the judge looks at your case and says, hey, you know what? Your case, I'm not dealing with your case. You need to go to mediation. If you agree, you sign an agreement. That agreement becomes now the document that's going to be put in the court. Now, here in America, I am working in a court where we are doing with a lot of family mediation. Family problems are becoming a lot. Now, let me tell you what has happened in Kenya. They have started what they call court annex mediation at Milimani courts, commercial court. These courts, what they are doing, when you have a dispute, for example, families are fighting over property. Mzee amekufa, the children are fighting, a lot of money is being spent, the lawyers are eating a lot of money. Now the courts have said, we don't need that. Because the whole idea behind mediation is to save the relationship. Usually when you take somebody to court, this is what happens. There is a win-lose situation. What happens to the person who loses? They get angry, the relationship becomes worse. In mediation, we have win-win situation. So we are in the process of coming to Kenya. I live here in Dallas. I've been a teacher. I taught a lot of students in our high school and in our junior high school to resolve their own issues. We are also doing it in the families. We are also doing it in churches. We are also doing it anywhere. We are talking about people investing. Let me tell you what one of the things people ask. If I have a dispute in Kenya and you are telling me to invest, how is my dispute going to be resolved? Is there a system where you can resolve my issue? The first thing they'll look at, they say, wait a minute, these guys don't know what they are doing. These guys have no clue. I'm not going to go there. So it is going to bring you a lot of money. Since 2016, since Kenya started doing this court annex mediation, they have saved $7.7 million. That is almost 800 million that has gone back to the community, that has gone back to development, just because of the way they are resolving their dispute. So as governors who are here, you are going to save a lot of money. You are going to bring a lot of resources in your county, because the courts are holding a lot of resources. They are holding a lot of money because these cases have not been solved. Now, what happened? I noticed one case in Kenya took 16 years. Now, with mediation, it's taking 66 days to resolve issues. That is money that is being released. Talk about healthcare. There is a lot of mediation in healthcare. Talk about business. Talk about labor. Anything you can do. The only thing we don't do in mediation, we cannot mediate criminal cases. Obviously, you can kill somebody and let's sit down and talk about it. No, we don't do that. But to cut my story short, mediation is the next thing, is the next way of solving problems. It is important that you do it. I have a master's in ADR, that is Alternative Dispute Resolution. And as a former teacher, I know what it means to teach students in school to do it. Nurses can do it. Everybody else can do it. All these county-to-county disputes we have, it is happening, it is working, and we hope to see it in Kenya because we are doing it. May God bless you. Thank you.
Thank you very much. Thank you very much. Let's appreciate everybody who is here for a job well done. So we can dismiss this panel, and I'd like to call the next panel, which is the final panel, to the stage, please. This panel is being moderated by Elizabeth Oduor from Diaspora. It's chaired by Joyce Laboso, and the panelists are Ambassador Hussein Dado. Take your seats, please, as I call you. Honor His Excellency Stephen Sang. I think I saw him out there somewhere. Senator Kangata Irungu.